Hey, good afternoon. My name is Sang Lee from Johns Hopkins University, orthopedic surgery. So I was really excited to moderate this most favorite sessions, complications. So first two topics probably is cervical spine specific, and next two topics could be general, but we can focus on the cervical spine.
But next is Paul Arnold talking about management of vertebral artery injuries. Not because you have a lot.
Not a lot, but somehow the organizing committee knew I had at least one, so I'm going to lead it off that way. So I'm going to start with a case. This is my case. This is a 65-year-old lady with left upper extremity radiculopathy. She failed conservative management. She had some paresthesias, and she needed what I would hopefully most people would agree might be a C5-6 ACF. I did not monitor this. She had no myelopathy, and there was generally speaking, no salient reason to do that. So it was standard C5-6 ACDF, usually go from the left because that's how I was trained. Profuse bleeding while I was removing osteophytes in the left C5-6 frame and toward the end of the case. So we packed it off with flow seal, thrombosol gel foam, cottonoids, sponges, and a lot of prayer. The bleeding was actually controlled after several minutes of pressure. We were able to continue with the case. Once you get the bleeding stopped, if everything's going okay, you don't want to bail out, you want to finish it. So we were at the point of putting the bone graft in, so we put the bone graft in, put the plate on. And because, this is more than just sort of the usual, sort of bleeding at the end of the case, so I have several IR partners who I can trust and rely on, so I called them, and they said, well, let's bring the patient to the IR suite. So we didn't wake the patient up. We took the patient well into the IR suite's just down the hall from our OR suite. So they were there to meet us, and the patient was already asleep. So we went for angiogram and possible treatment. Patient was a little hypotensive. The systolic blood pressure was 60, so we just placed on pressors and IV fluid. We did not really feel like we had to give her any blood. So I'm going to again go through this, and at the end I will tell you what we did at the end of the case. So vertebral artery injury, there's not a lot of huge literature on it because thankfully it's pretty rare, but it is the most common vascular injury in cervical spine injury. I'm only talking about iatrogenic ones, not traumatic ones. It can be injured in any way you can think of, either anteriorly or posteriorly. Again, they're rare, but the consequences can be devastating. And vascular procedures over the last probably 10 or 15 years have evolved to really help treat these injuries instead of just packing them off and ligating them. They can be fixed endovascularly. So I'm going to talk about the epidemiology, a little quick review of the normal anatomy, the iatrogenic vertebral artery injury according to the approach, and then strategies for managing the problem. Prevention is the best therapy. So if you never get one of these, that's probably the way to go. They get chest pain from enough of these probably if you get them. So the most common vascular injury in cervical spine surgery is a vertebral artery injury. Most common causes are use of a drill or abnormal placement of instrumentation. Other causes can be soft tissue retraction, or if you retract down and you don't know it's there, removal of OPLL, cautery dissection, which I had a colleague get into once, using the the monopolar over an area where the artery was exposed and got into that. Vertebral artery manipulation or aberrant anatomy. So the mechanisms are many. You can lacerate the artery, which makes it difficult to repair. Get a pseudoaneurysm, an arterial dissection, and these will come with thrombosis and emboli and then occlusion. Symptoms can be immediate or appear months or years later. So these are, it's a little like porn. You know it when you see it. If you get into this, it isn't just sort of a usual. I'll put some flow seal on it and it'll stop in 30 seconds. It's pretty bad. Get a lot of intraoperative bleeding, can get delayed bleeding, get posterior circulation infarcts, neck swelling with dyspnea, death, altered mental status, hemorrhagic shock. The majority of symptoms occur pretty immediately, but they can be delayed due to an AV fistula or pseudoaneurysm or an embolus. So you have to, if you do get your patients, you have to follow them for more than 6 months, and our vascular people sometimes follow these people for years with further angios. So the incidence is pretty low, thankfully. These are, the AO did a pretty large study with 15,000 patients and got, less than 1% of patients get this injury. There's other studies that are listed here, and these are the causes in this chart here on some of the other ones and how they were taken care of. a lot of them with packing and then an angiography. So you can see a lot of them with the burr, so you need to be very careful. You can use a drill, occasionally electrocautery, but a lot of them with burring. So this is a quick review of the normal anatomy. V1 is from the subclavian artery to the transverse process at C6. V2 is from C6 to the transverse foramen of C1. V3 is the superior aspect of the arch of C1 to the foramen magnum, and then V4 is the intradural part. So anteriorly, the vertebral artery is most likely to be injured at C7. Laterally, it's C3 to 7 if you're going to put a posterior screw in aberrantly or get into the problem in the foramen like I did, or an anomalous course, the vertebral artery can occur in up to 5% of cases. And then you have to remember that it curves over the arch of C1 intradurally as it joins the other one. It's paired member on the other side, so you can get into it posteriorly at the C1, C2 junction if you're operating there as well. So you have to be careful there as well. A CTA can be useful to assess anatomy in the preoperative setting. So if you think there's something abnormal on an MRI or a CT scan, then a CTA is certainly useful to evaluating the anatomy preoperatively. So this, you can get injuries by the anterior approach. This is thankfully not in my case. It's usually the most cephalad vertebrae, but the etiologies include drilling, which is, again, I mentioned the most common cause, lateral disc removal, hardware placement as this person got off-center, tumor infection or lateral explanation or a cautery. One of my partners got into it with cautery a few years ago. Prevention is obviously care at the uncovertebral junction, evaluate the preoperative imaging, careful attention to landmarks, and if you're worried, bring in the fluoroscope and lay the plate over where you think it should go and see if it's in the midline or not. There's certainly no downside to that. So injuries via the posterior approach, usually the most common is through a C1, C2 transarticular process or transarticular screw placement. And mostly, they've been replaced by the Harms technique, so the incidence has gone down due to this. You have to pay careful attention to the anatomy and preoperative films, make sure there's not a high-riding artery where you can't place a screw there. There's no good path for the screw as you get into C1. And then if you have to, and we've completely switched to Harms technique for a C1, C2 fixation. You can do that with navigation. It goes pretty straightforward. We talked about this a little bit during the odontoid fracture session earlier this morning. So screws placed posteriorly are a very, very rare cause of vertebral artery injury in the subaxial spine. Abumi had one case in 180 pedicle screws in 2000. It's even rare for lateral mass screws. There's a pretty big margin for error. And very, very even rare to get it during decompression. The case reports of a pseudoaneurysm or of an AV fistula. So the management of them. So you're going to get sudden torrential bleeding. Like I said, you'll know it when you hit it. There's no consensus on definitive treatment because it's a pretty rare, thankfully, phenomenon. So the goals of the management are the control of hemorrhage, prevention of immediate vascular complications, and prevention of other complications. So you want to tampen out the bleeding, add fluids or blood if you have to, and then probably angiography or direct surgical treatment. This is an algorithm for intraoperative vertebral artery injury, and I'll skip through that because I got a few more slides to go. Surgical treatment would involve a tamponade with gel foam, Surgiseal, Flow Seal, potentially a microvascular repair of anastomosis, but you have to have two good ends to repair to. So if you've gone through with a cautery or sheared it, you're not going to be able to do that. You can ligate the vertebral artery, but there's a risk of a stroke with that, and you're going to need angiography anyway at the end of that to evaluate what you've done. So the microvascular repair restores normal blood flow. This is very technically challenging, requires two ends that can be sutured with sharp margins. It's more appropriate for the dominant vertebral artery. Ligation or occlusion can be associated with a cerebellar stroke, cranial nerve palsy, hemiplegia, and it should only be used if there's sufficient blood supply from the contralateral vertebral artery. The risk of a brainstem infarct is very high with the left side of vertebral artery occlusion. So endovascular treatment, I think, is probably becoming the mainstay for this and is becoming more and more common. It's probably the best option. There's a lot of good options or treatment options that the IR folks can do. They usually get a 4-vessel vertebral angiography to assess the anatomy, and then the options include occlusion, trapping of the lesion, coiling, or stenting across there to prevent a pseudoaneurysm. So these are the options: a covered stent, multiple stents, or flow diverter to maintain vertebral artery patency. Covered stent can completely seal the arterial laceration. These are best for V1 or V2 injuries due to the rigidity of the stent. Single or multiple stents are used for pseudoaneurysm or dissection, and a flow diverter is used more recently, best for pseudoaneurysm rather than active bleeding. So you need to have multiple follow-up studies to assess for late pseudoaneurysm or arteriovenous fistula. CTA, MRA, or angiography can do that, and you need to anticoagulate the patient postoperatively. So strategies for prevention would be attention to preoperative studies. This is obviously the best way. You don't want to have to deal with this. Meticulous surgical technique and knowing the landmarks, minimal traction, and assess the path for your screw trajectory, either anteriorly or posteriorly. So my patient was found to have an injury at the V1, V2 junction. She had a codominant vertebral artery. The right vertebral artery filled the basilar artery retrograde to left V4. So the patient woke up neurologically normal after she was, and I'll show you the picture, she had a pseudoaneurysm, was coiled. She was anticoagulated for 3 months, and she's doing well 3 years after surgery, so she had no sequelae after this, after the IR folks were able to bail me out. So this is what happened. This is the injury there, and this is, they put a coil in there, basically coiled the aneurysm, and I was, we were able to, she did fine afterwards. And it actually is done well. I saw her in the office a few weeks ago. It's 3.5 years after the index procedure, and thankfully she's done well. So keep in mind, if you're going to do this, that the IR people are probably going to be your best bailout for this problem. So thank you very much for your time.
Ahmed Nasr, Rochester, Minnesota. For Paul, great talk on vertebral artery injury. Fortunately, I think most of us don't have a lot of experience with this, but I did want to make one comment. I know for hemostasis, a lot of us have Flow Seal or an agent similar to Flow Seal that we use for hemostasis. I would just caution that if we do have a vertebral artery injury, it may actually be a disadvantage to use that around the artery, only because it can actually embolize towards the basilar. So I did have one patient where that's exactly what happened. So I used Flow Seal. When I took them down to the angio suite, there was no flow through the basilar. So it was quite disastrous. So they were fortunately able to get that to open back up, but it wasn't a clot. It was much more than that. It was probably the Flow Seal had embolized. So just a word of caution not to use those agents around an arterial injury. So just a thought.
Yeah, I agree. I had a comment. Arbutin powder is also very risky. It can go to the vertebral artery and basilar circulation, can make a bad stroke.
Pasquale Montesano, Sarasota, Florida. I'm not sure how many are aware of a supplement that seems to be used more and more, Kava. It's been outlawed in Germany, Poland, and several other European countries, but it causes massive bleeding. And so I've changed my preoperative discussions to include no dietary supplements along with the usual no aspirin, Indocin, Motrin. Second comment was, I noticed you had Toradol on your protocol. I haven't checked the PDR recently, but I know that for a while it said not to be used in the perioperative period, despite the fact that a lot of people have been using it because there were some massive bleeding problems reported with it. I'm not sure if they've changed it recently. I haven't looked at it, but it did say not to be used pre or post-operatively.
Kirk Owens, Louisville, Kentucky. I just have a question about the vertebral artery talk, and I'd be interested to see what the panel says. Do you guys have standard imaging that you do? Do you rely on your MRI? If you're doing upper cervical fixation, do you get a CTA to check artery anatomy as a standard?
So I'll take that. So recently I've been taken to getting, everybody obviously gets an MRI before surgery, and if there's any question at all, I get a CT scan because I've been fooled or misled where you think something's a calcified disc and they really have OPLL. And so rather than getting fooled, I get a CT scan and a lot of people either that or a plain X-ray on nearly everybody to make sure that they don't have that problem. And then if there's any kind of anomaly, when I take a close look at that, then I'll get a CTA.
Anybody else get CTAs for C12s or just
So-
as a standard or a CT? Because obviously the anatomy at C2 can vary depending on, you
Yeah,
know,
I will
pars or
always get a
pedicle.
CT, just a straight CT for all my posterior, because there's enough variability either with the vertebral artery path or with just the size of the pars or pedicle that you're treating. But I don't routinely get a CT angio for those. I mean, there'd have to be something
Something anomalous on the
anomalous
CT.
on either the CT or MR to suggest that.
Yeah, that's for every CDF, when I'm indicating for surgery, I try to follow the transaxials and look at the vertebral artery and follow it all the way up and down. Very oftentimes, it's wrapping up towards the longest and in and out. If there's any question that I don't know where it is, that patient's getting a CT angio, just so I know.
For upper cervicals, I always use a CT. I think you need to look at the bony channels. My threshold for a CTA is pretty low, but I don't do it routinely. If I get any suspicion, a whiff of anything that's funny, I'll get a CTA.
And I get a CT for if I go to C1, but I don't get a CT routinely if I'm going to C2.
The one anomaly where I've had two vertebral arteries over the years, one from a transarticular screw. There's an anomaly where the vertebral artery, rather than go through the transverse foramen at C1, actually comes into the canal between the lower arch of C1 and C2. It actually rides right where your C1 screw is going to be. And so if you have any suspicion about that, you better get one.